Here we are. Dr. Sharma,
Okay,
you're on.
Good. So we got our team ready here. The Amit Huda is my associate today, and we have our two interventional fellows ready to work, Anup and Hitu, and rest of the cath lab staff. I'm sure everybody knows those from our CCC live cases, and every year, almost everybody is Ultim, maybe one new person, right? But everybody else is the same for many years. Okay. With that
Wait a
case,
minute before
we
you
start.
Okay, here we go.
Yeah.
Go ahead. This is the 75-year-old woman, right?
Yeah, 75.
Let's go.
This is the patient who had risk factors as shown there, class 3 angina, and patient had two vessel disease of the circumflex and LED diagonal. The circ has been taken care, and today is for LED diagonal bifurcation, and patient is appropriate because of the two antiplatelet therapy, and secondly, because a patient has positive stress test. So both symptoms, dual antiplatelet therapy and positive stress test. Maybe we can show on the screen now, all the staff here. So I know they are getting ready. It takes a little time for the laser to get warm up, but hopefully with the heat of this room, things will warm up there sooner.
Okay.
So
let's
with that
go.
note,
Show us the anatomy.
So let's go to the anatomy here. This is the case, as I mentioned, that they had done the PCI of circumflex. RCA is good ejection fraction, but circ stent looks very good. You see that large one?
Yeah.
And then this is the LED. LED diagonal bifurcation. Actually, the diagonal is much more tighter. It was about 70% just about a month ago, and now it's like 99%. And very calcific. The LED, you can see, question is whether you call it a moderate or severe with a tram track, and knowing that this is kind of an imaging atherectomy conference, we put we said this case we'll try to do orbital atherectomy, and this is I was in OCT in preparation for atherectomy, and you see that we did this is done on the Viper wire. So if we can show, and we need to hear from our experts that what are we seeing on the OCT.
So this is just a level of the diag. We can see the diag at the 7 o'clock, and a little bit more proximal. We can see like 360 calcium, very thick calcium. So I can measure the thickness of the calcium. It's like 1.05 and almost 360 calcium. And I go to proximal, the lumen is getting bigger, and looks like here is a little bit better lumen. And go to more proximal. Still a little bit chunk of calcium, but here the lumen is open. So the tightest is just before the diagonal, 360, very thick calcium.
So it is a 360-degree arc of calcium with a lumen of 1 millimeter and thick calcium, but no calcific nodule. Compared to the earlier case which we showed, no calcific nodules. Is the long segment. I just wanted to remind everybody, this is the angiogram, and we are ready with the orbital atherectomy. Okay, so this is orbital, as you know, is a 1.25 bar. And I know that everybody has spoken that what should be the question is you do is rota versus orbital. These are the kind of cases, the majority of the cases you can use either. And this is the type of case, not angulated, and the orbital is good enough. So we are going to show orbital with a 1 point, which is only single bar and only 80,000 RPM. And I know this has been spoken quite a bit. To me, I think in the orbital, and of course, Roxana, you'll have a discussion with the faculty. I think they should not even have 120 for the coronary. 80, rather 40 should be even better, because any trouble we had in the beginning with the orbital, all were cases with 120,000 RPM, and you can ask the faculty.
We have a great panel. We're going to discuss that. But my big question is, why the LAD first? I'm a little bit nervous that with going into the LAD, you might compromise after you do plaque modification. You might move some plaque into that very tight diagonal. I wondered why you're not doing the diagonal first and then moving to the LAD like we saw in the previous case that Dr. Kinney did.
Right. No, I can tell you the reason is, look at that. I think the diagonal we can do with a balloon. And even OCT was very tough to push. I was ready to take it out, but then we pushed again and it went through. So the lesion before the diagonal, you see that? That's the tightest 1 millimeter. The lesion is so tough. So if we start going into the diagonal, we'll start the cascade of the balloon angioplasty and so. So goal here is hopefully by debulking, whether it's orbital or rotational. Rotational we have shown that less plaque shift and less occlusion of the side branch.
All right, well, let's see if that's the case.
Yeah.
And as you're doing that with orbital atherectomy, we've got a great panel here. Bill, how often do you use orbital atherectomy over a rotablator?
I really don't use it because I use, when I have a really heavily calcified vessel, I use rotablator, and then for less calcified, we're using shock waves. So, I mean, you have to kind of pick, but that's our algorithm.
Holger, what's your thought about the use of orbital atherectomy here?
Yeah, so we probably would have used just normal rotablation in this case, because at my institution currently we do not have orbital atherectomy, so it just has been approved in Germany very recently, and that's the reason why we don't have it.
Jackie?
I just want to make a comment in response to Dr. Sharma's comment about the rotational speed. It's true. I mean, personally, I have never used anything the larger speed, the higher, faster speed, because the only cases I've seen the higher speed happen, both of them had resulted in a rupture. So,
any other comments on the speed on this panel, John?
For rotablator? For
The
this?
speed of the orbital atherectomy. Are you going to the lower speeds now?
Yes, pretty much, almost universally.
Universally,
you know,
Jazz?
Jazz,
I
I would
agree.
definitely
I agree with
Srini?
Dr. Sharma. You should not do 120. They should take it away from the coronary.
I think there's a much more latitude
Beautiful.
with a rotablator where, you may start at 160, but I quickly go up to 180, and if it's not going through right away, you go up to 200. I realize that violates some of the basic principles about heat generation and platelet aggregation and all that, but there comes a point when you've got established flow, which will mitigate against most of those problems. So rotablator at least gives you the latitude to go to a higher RPM and get through the lesion.
Yeah,
Go ahead,
the
Jazz.
other thing, in this orbital makes a little bit more sense is, I'll tell you, because of the diagonal you were talking about, when orbital goes through this calcium, and if you're a patient at 1 millimeter per second, you actually not only are treating that thick calcium that you saw in OCT, but you actually are doing deep calcium also, which will affect that bifurcation that you do. And you can see actually the compliance changes after orbital because the way it rotates and does it. So I think theoretically it makes sense to do orbital in here.
Srini?
So therefore, what we did is, they see this 1 millimeter, but just see this now. And so I cannot push it further. It's not making the band. So clearly, and I have been the big proponent of this technique, that in a long calcific lesion, don't think about going through all. Use 60-70%, you have cut the calcium, and maybe that will be good enough. Otherwise, we'll come back again. So we are done here, and we are coming out with the DynaAssist, right? Yeah. The DynaAssist working now? Okay, good.
Dr. Sharma, can you go over that again? I think it's an important, very important teaching point.
So yes, if they can show, these are the two buttons. Focus a little more on the top, please. 80 and 120. I would say the 120 they should put a cross mark. And now what happened is to advance the device further, the crown they call, forward or backward, it's a glide assist mode. So we can easily advance or so. So this is when blinking. When the continuous means it is ready. But when you blink, that means it's on the glide assist mode and it will come out without any problem. So you're ready to take it out? Yeah. Okay, keep the wire there. Yeah. So see, the same process, all these, both devices, atherectomy or OA or RA, both are on over the wire system. 1 second, slow.
What's happening?
Yeah, the key is to go slow.
We lost the
Go
wire
slow.
position,
But, okay.
but importantly
So,
I also noted
but that
your-
wire never went to the lumen anyway, distal lumen.
Yeah, I also noted that your the distal wire position was not ever perfectly down into the
No,
distal
it was
vessel.
very tough, very tough.
Doesn't look good. Doesn't look
Yeah.
good.
Good. So this is what?
So what's
Get
next?
a 2.5 compliant balloon.
What have you got
So
next?
clearly, right now we have the two wires. One is the run through, one is the fielder. We'll try to go into both the branches and see whether we need to come back and do complete the rotablation. I mean orbital or we go with the rotablation, because I was a little concerned the way it did not make that turn. You saw that I was pushing. get a filter wire for the
Sometimes
diagonal.
this flex tip wire,
Yeah.
there is some rare circumstances where it's not as supportive, but it's very good for wire bias.
I know.
So what happens is
Yeah, that
sometimes
is
you
why
have
we
to
did it.
switch
Yep.
to the advanced wire, and that actually allows you to
Yeah,
take it in a
that's what I was
straighter
thinking.
segment.
Yeah, but Jesse, let me ask you, would you have used the advanced wire in this case? This is the kind I teach, that this angulated, you should go with the Viper Flex.
No, absolutely. I think Viperflex is good. There was aneurysmal remodeling past your lesion,
Yeah.
so you don't want your bias to, perforate and stuff. So I think you did good here. I really think that was good. I think you got through 3/4 of the lesion, so I think you modified it.
Lady. And I can tell you this concept of the incomplete atherectomy, whether it's orbital or rotational, it will probably decrease, in my opinion, complication of this procedure. Because you don't have many times with a long lesion when ready to come out, that's where the perforation occurs. So I think as long as the work is done, work is basically able to open the lesion. Now here, it was always a very angulated diagonal to begin with. If it does not go, I would not press at this time. I try to open the main vessel first and then retry again, because here we know that ostial of the diagonal was a pinhole this had on the OCT.
Which wire is that? Is it Whisper?
Yeah, actually right now this is the fielder wire, but let me leave this one for the time being. Let's open a little bit of the LED with a 2.520 balloon right now.
15.
15? Is it 2.5, 15 or 20?
15.
Okay, 15 balloon, good. Ready? And we try to open those areas and see what we get. Because same.
Yeah, I was concerned.
So we have
about
actually now
closing
shown the
diagonal.
rotational atherectomy, we have shown the orbital, and soon they will be ready with the laser. Okay, go up here. 6, 8, 10, 12,
12.
negative.
I think
And more calcium, circular calcium was more proximally.
Yeah, it's more important,
go
I
up
think,
here.
for you to modify and try to hopefully open some
Negative.
railway into that diagonal. I don't want you to lose that
Right.
diagonal. And you were supposed
Yes,
to show us your final
absolutely.
result of your
Well.
previous case. So we still want to see that.
Yeah, we have that one. I thought you saw it on the side. We
No,
used
no.
one more OCT catheter. Bifurcation case, the case they told me was playing on the side.
I know, but we
Came
were
out good
we
with
were
a
working.
4.5 and okay, we'll show it again. Yeah.
You'll show it
But
again.
I can just, yes, the key is that maybe I need to learn a little more OCT, because the second catheter, new catheter also didn't go up. And I documented that. It did not make a turn through the maybe stent struts or so. We opened the new catheter, earlier when you saw it,
Yeah.
was not going. In the new catheter did not go, but we documented that. But then we have great angiographic results, and the fellow still wanted to do IVUS or some other technique. I said, good, put the IVUS catheter on the patient's chest now. I think 2 OCTs are good enough.
So is there any, is a patient having any chest pain? Because I'm seeing some EKG changes.
No, this one ST elevation. Yeah, definitely. The patient has EKG changes. Now, before we give dye, always try to see ST elevations there. I'm definitely concerned about the diagonal.
I'm seeing depressions that are concerning
Yeah,
me there.
yes,
I want you to open that diagonal.
has to be. All right, let's
Just
see it to
saying,
believe
I
it.
have eyes behind my head here. Don't think I'm not in the lab.
Yeah.
I'm not seeing these things.
Yeah.
Well, good thing you
Pressure
did
is
lose the
good.
diagonal.
I would give some vasodilators now. It'll open it up. I think
Yeah, we
you
just
got
gave-
Here
flow.
it goes. Here
Yeah,
it goes.
we
Look
gave
at
us-
that. So that's a great.
Yeah, we
that's
gave-
a great example of plaque modification. A little balloon angioplasty, changing, and now we
Yeah.
see flow into the diagonal. So it's great to see
Look at that. Diagonal looks better than before without wiring.
No, but I think it's
I
a
think you
really-
have a better retrograde flow to the diagonal.
I mean, I think one of the things was, I think that the takeaway here was we were struggling, right? You
Get a
saw he
whisper.
was struggling
whisper,
wiring.
whisper,
Instead
whisper.
of struggling and dissecting more and creating more havoc, he changed the plaque morphology into the main vessel,
Yeah.
open, and hopefully now with I think you're going to need a whisper. He's going to get into that
Yeah.
side branch. Side,
Yeah, we are
side
getting the
branch.
whisper ready, yes.
Yeah, Samin, you wanted to show us the orbital, but don't you think the rota would have been easier in retrospect?
If you ask me, yeah.
Yeah, don't
Yes,
ask him.
yes.
He's always
But-
going to say that about Rhoda.
No, but I think in this particular
case.
case, no, I would say in this particular case, I think the 1.5 rota bar would have gone through and through, but the whole purpose here is to show actually, you know what, I'm a little happy that I did orbital, and we actually have another case of the long lesion where we'll do a 3/4 of the rota, we'll purposefully. In this case, by default, we could not go completely, but I have another case today where we'll do a 70% rotablation of the lesion, not complete, and show that that's good enough. But I think we need to go to Whisper. Lil Die now.
Yeah, I think this is like a CTO pretty much. The calcium is stopping you from going, and you're hooking it. So you may need something. Yeah, there you go. You got it.
Yeah.
You got
So
it.
this is what's called a
Like a
Cardellino
little balloon.
a maneuver, or sometimes called a suicide maneuver,
Yep.
where you modify a balloon over the side branch. The risk, of course, that you're going to lose it, but in actuality, you clear out a lot of the plaque
Yeah,
that's
it's a
inhibiting you
great
from getting
teaching
into it.
point because many people are scared to do that. You know, in the middle of this, I mean, you feel like you're definitely going to lose. You're never going to see that side branch again. And here, it changed it to the better.
Yeah.
And,
And obviously, you like to-
And actually, you know, let me make a point on that. And we published this almost 20 years ago. That you have a very tight lesion, and many times the branch comes off after the lesion, and you cannot get to the branch. So what you do is you put both the wires distally like we did in this case. So even when you are doing a balloon, you are creating the cracks, but your wire is in the main lumen. And that is why we were able to get the same, the fielder wire of course required a little manipulation, but I remain in that cracked plaque of the proximal mid LAD. So this is the K. So I know that a lot of people call us suicide. We do this routinely, and I would say maybe if we had done those kind 100 times or 2 times we are penalized, but 98% of the time it works quite well. So this is the 2O15 balloon.
The same concept is
But
true
easier,
for
but
pod
both,
when you're doing
both wires should be distally, yeah.
when you have bifurcation and you cannot recross. If you do good pod, it's much easier to cross or to recross. So it's a very similar concept that
Yeah,
by
pod.
dilating
So
the
if you-
area.
And if you don't
better
put two
channel.
wires down, you could always use a Suzuki, right?
yeah.
Just
Yeah,
slide over
that's
the one
true.
that you've got
Yeah.
interluminal, and you put the wire out the side.
I get that.
Yeah, but
So
you know,
is-
with balloons, Roxy, the balloon, this is as high risk to close with stenting. So balloon, okay. But with stenting, because of the angle, because it extends 10 millimeter past it, and it's calcium, that's your enemy in bifurcation. So I think with stenting, this will shut
The
down.
stent we are
So
going
you
to
really
what?
have to
Yeah.
figure out
Science,
what your stenting strategy is going to
2518
be.
in the
Yeah,
diagonal,
and I guess
here,
that's the big question, Dr.
3038.
Sharma.
38,
Yeah.
038 and 2.25.
Dr.
Yeah,
Sharma,
I'm saying,
the-
okay, what is the
what's-
question now? Go up.
Yeah, the question is are you going to do provisional now here for this side branch?
No,
or
no,
are
no.
you already
No, I think it's a very
committing
good
to
diagonal.
stenting?
No, I think it's a 2.25 diagonal. We'll do plan it to do a mini crush. This is the 7 French little die, 7 French VL 3O guide. Go.
I
We
don't know,
want to
though.
do a mini crush. Yeah.
So,
Why
so
do you
Dr.
want to
Sharma,
do a mini crush here? I don't know. I don't know that I agree with that. Ron?
let me ask you a provocative question. If
Yeah.
we had the available DCB, would
Would
you do DCB on the
That I can tell you.
diagonal?
No, I
and
made that
stenting
point.
on the
I
LED?
made this point. If we would have a DCB, this is the beautiful case for DCB, 2.25.
Exactly. yeah.
Well, we don't have DCB.
I disagree. I think
Yeah.
DCB is not proven, especially with these high-risk features of a calcium angulation and extending that much past the distal
You're 2.5.
vessel. It's a very high risk for closure. So, you know,
But look
DCB
at, yeah.
may work, but
look
you
at the
technically
Roxana.
you'll-
This is a good size vessel, 2.5. I mean, let's say if the LED was okay, patient come back with the diagonal, we are going to put a stent in the diagonal. So I always say that your side, what is this now?
Yeah, and DCB was more for smaller vessels. This is a very large diagonal, too.
No, the diagonal is pretty small in caliber, I think. Jackie?
No, I was just going to say.
We're
in
putting
this
a
case, I'm
2.5.
more worried about the structural benefit of the stent as opposed to the restenosis, because it's more about the calcium, and putting the stent in the main vessel is going to close off that, and a DCB is not going to change that risk.
Right.
Okay, so you're doing another mini crush here. Should we go to,
Yep.
should we stay with you, or you want us to go? I really don't, I'm
No,
really anxious about,
You
I
need
want
to
to
see
see
this.
Dr. Kinney.
No, you need to. Yeah, no, but you will go there, but let's see this real stuff.
No,
Mini
the
crush
real
and then you
stuff
go.
is in the other room. The real stuff is in the other room, Dr. Sharma. Sorry to say.
We'll make it. But listen, a few technical points we made here. Half orbital atherectomy, then it's a good size vessel. Not dye. Don't give dye until necessary. You give it now. Now you show it. Little dye.
Don't give dye when it's not necessary. Remember that.
That's it.
I've taught him. I've taught
Very
them
important
well.
point. Yeah, good.
Well, we should point
the
out that
diagram
it's
does.
June and a lot of the new interventional fellows are just starting.
Yeah. And
But is that really a mini crush? I don't know that you're in the LAD.
yeah. Oh, yeah. You'll see it.
All right.
Or we call ultra crush. Okay, now, let me tell you what we do. Little modified technique of the decay crush. So what is the difference in the decay crush and mini crush? That you're opening the ostium before you putting the stent in the main. So let's say the Sharma's modification, now you go 20 atmosphere of the ostium. So you go extra mileage
That's a-
to open that
that's the
ostium
Sharma
negative.
way.
And then, yeah.
That
So
is not, Kenny did not do
always
that.
not in the pot. Yeah,
Okay.
good. Little dye, just see it, little dye. We took the wire out.
You know, I'll give you another modification.
Then-
That's the Sharma way, but you know, if you had just left that balloon in there and deploy the LED stand,
Yeah.
you push the
Yeah.
stand a little bit back
Yeah.
and then reinflate that balloon that's trapped, reinflate, correct it, and then reinflate your LED. You have a decay crush with 5 steps less.
Oh, I see. That's an interesting.
Good one, another good one.
Okay, is
Lot
this
of modification of the DK crush. One
stent?
sec.
Is this a 3.0 stent you have? This, because I
Yeah,
hope you're going to
3.038.
go a little
Yep,
bit higher
this is-
than a 3.0. I'm sure this is a little
Yeah,
bit
this-
bigger than a 3.0.
Okay, what was the vessel size on the OCT?
Sure. The best size is
On the OCT, I thought it was just
Yeah.
3.25 there.
Yeah.
We are going to do a kissing balloon anyway.
Yes.
Ready?
Yeah.
Are you believing in pot, doing pot now?
Good. No, I would kiss. Remember in the non-left main, we actually have the paper also in endothelial shear stress and pro-pot. Remember the pro-pot was majority was the main, the non-left main. And what was the pro-pot overall analysis? That's the first randomized trial, which showed that you have a percent of the mal-approach stent were not lower, rather p-value of 0.1 in many segments. And our shear stress paper also showed the same. Kissing balloon versus pot, and we can show that slide, published, I think CCI, the circulation cardiovascular intervention. That kissing balloon, I think nobody actually has real data to show that pro-pot will be better than kissing. One trial, pro-pot trial, showed no benefit. We have our data. So we will do the left main, definitely pot, but others if necessary. Because if I have trouble here, I will go with the balloon, our 2 balloon into the side branch, then maybe we can decide to do the pot. But otherwise, to
Dr.
me,
Sharma,
I personally think
I'm-
our teaching is, yeah.
In this last angiogram, I think you did a nano crush, not really a mini crush. I'm wondering.
But that's good.
I am still wondering if you actually made it into that ostium because it looks a little bit hazy.
Let's
Take
see.
a look.
Okay, 1 second. Yeah. First is, let's hear. You see the stent is fully covered. We magnify further.
I don't know. Play it.
I think more
Play it,
magnification.
Sam.
Yeah. Okay, no, I know, but we'll do it also. But look at the angio first. Yeah. That's one now.
You know, if there is
Also,
a
I
question,
tell
you can
everybody-
IVUS this or
I don't
OCT
think
this,
he's
and then
covering
you'll
it
know
all
for
up.
sure.
No,
You don't have to
no,
struggle.
no, Roxana, one more thing yet. What happens now with the kissing, the top part of the stent of the LAD will
Yeah.
become 1.1.
Okay.
1.1, because once you do, it's going to cover that whatever 1 millimeter you are missing on the top, become 1.1 here.
Okay.
See this
Because I
now?
think there's a little missing
Here.
on the top. You see?
Yeah, so but that one, but we do a kissing. Remember the top strut of the
to
LAD,
change
now
the
going
view.
to cover that ostium, yeah.
Yeah, the thing
And
about
rather
pot,
so-
pot here is because they image with OCT and they size their stents. If you don't image, you have to do pot. I mean, you have to image anyway, but I think the imaging here was important, so they sized the stent well, and you can then recross. The thing about kissing here is, you should always, the data is that you should always have a very short overlap. You don't want long overlap because then you deform the stent proximally, then you have to report that
No, it's
proximal
really,
area.
really good. And you see it's really a minimal overlap. Let's hear from Jason.
About 12 handy,
Jason, any
50 cents
any
each,
comments
but
here
zero.
on the overlap and all that?
At the main
Two
balloon,
things.
main
One, I
vessel
think,
balloon.
Main vessel balloon.
when you
3O.
do LED diag
we have
bifurcation
3O20 high
with
pressure is good.
calcium like that, I
Your
think it's
3O20
very
high
key to be more
Yeah, go up. 20
eleocranial
at
than the
most.
REO
3O20
or
high
ET
pressure.
that Dr. Sharma's in now, to see the true ostium of the diag, because you could see that, like you said, Roxana, it was off by about a millimeter.
OCT is ready?
But the key also is to reduce the restenosis, because it's going to restenose in the ostium of the diag there.
Right.
Is the post-dilatation there.
Yeah, so we're going
fully.
to see him do now that.
Next.
Holger,
Yep.
and then we'll go back to Dr.
And-
Sharma. Holger, any comments?
Yeah, and we'll show you the IVUS here. I mean OCT actually. I don't know why I'm using word IVUS. Initially we were thinking that OCT whether make a turn or not. I think there may be a little wire bias. 1 second. Yeah, go up here in the side branch, so that we can get. Anytime you have trouble, there may be a mixture, intertwining of the wire. So just go low pressure, and then you'll be able to anchor whichever vessel you want, and it will go in. Yeah, negative.
Very nice. Nice little trick there.
Yeah, so now 1 second, we are going to do proximal, and then we document on the OCT that ostium is fully covered. Go, both of you.
Okay, that's good.
The,
You're
the other
proving
thing
it.
is important is when they have
12
these
and down.
important bifurcations, crossing through a distal stent strut is very important. So I would take time, image, do stent boost, and make sure you're crossing the distal stent strut, because if you cross proximal, you actually pull metal and you actually deform the stent. So distal is very important.
Okay, Holger?
Yeah, I'm looking forward to the IVUS because I'm also not 100% convinced that the ostium is really fully covered, but we will see it.
We'll see it, exactly. He's going to
Yep.
prove us wrong, because, he's always right.
All
Dr.
right.
Sharma.
No, I can tell you, I may not be so, but let me tell you first, on the angiogram. First thing first, I'm going to tell you based on the wire. Let's advance the
I
wire a little
called
bit.
it, but, I called all these things. I said, be careful you don't close the diagonal. I would treat that first, and it went down. I think it's also the ostium is
No,
not
diagonal
fully
didn't
covered.
went down. No, diagonal did not go down. Diagonal got better flow, Roxana.
First it
After
went
the
down,
orbital
then you
atherectomy-
made it better. Then you made it
No,
better.
diagonal never went down.
Okay.
Diagonal never went down. Remember, after orbital, diagonal got actually, it was angulated, it was difficult in crossing, but it never went down here. It was basically, actually, we were surprised that after orbital, I want to teach everybody there that look at this case, we started after orbital atherectomy.
Well, where's
This
that
is the
diagonal?
diagonal.
Hold on.
Yeah.
Show us the
Come here.
diagonal after
This is the
orbital.
diagonal. This is the
No, that's
diagonal.
before.
This is the diagonal, right?
Yeah?
Yes. Right.
Now,
Ready?
orbital. Show us
Okay.
orbital.
Yeah. Yep. Right.
Okay, now,
And,
now show us the diagonal.
Orbital. Yeah. Yeah.
Where's the diagonal, Dr. Sharma, there?
Yeah. Right there. Coming. Bigger than before. See that? How bigger the diagonal is before that? No closure.
Okay.
It's a better. Yeah. No, that is for sure. The diagonal and same thing that once you do atherectomy of the main vessel, the side branch should not close. But let's see where the.
This is why we have
the
fun in
believe
live
it.
cases. All right, let's keep going. Show us what's happening now with your mini, micro, nano crush.
Or no crush. Let's see.
Actually, you
EKG is
can do
better, some ST
OCT,
depression.
and you can reconstruct
now.
it, and it'll tell you exactly where your stent is. So you only can
Yeah.
go in the main limb, reconstruct it, and it'll tell you whether the stents are touching or no.
No, do you want to go in the main or the side branch?
I think side branch, Dr. Sharma, because the main,
Okay.
you're going to,
All right.
of course, you have a stent there, and it's going to be hard to tell.
Now let's hope this OCT goes in because I'm not having good luck with the OCTs today.
I know, because you
I've
hardly use
already.
some.
OCT police is going to come after me. Oh, went in.
It went in. You have to just have, there we go. It's
I
not
think
Sharma
I was
speed.
It did not go in.
OCT needs to get to
No, it-
Sharma speed. You have to
Yeah.
use
No,
it
but
more,
are
and then
you
you
okay
tell
with
them
or
what
no?
to do.
No, the second marker is the camera, so it didn't cross.
No, it didn't cross.
No, but can it show us the ostium or no?
No,
It's
you are
still for
you
sure
are in the
again, what?
LED.
No.
We have to go, that
Yeah.
distal marker has to go now.
Yeah, but how do we do? This is
is
again
not
same story. So see,
Yeah.
this wire is very good position. I go back in, We have done the kissing. Okay,
Okay,
good.
now it goes.
There you go.
Are we okay now?
Little more.
Yeah.
Little more?
Yeah.
Yeah, a little more.
Yeah. You guys will dissect this
Yeah.
vessel.
But it's covered. Okay.
Are we ready?
Okay, just. So enabling. Yeah, please cine and inject.
Yeah, show us the longitudinal of the IVUS. We'll be able
Yeah,
to
yeah,
tell.
Yeah, perfect image. You can take it out.
Okay, we are going to go to the LED in case it's needed.
Sure. Yeah, looks
good,
covered.
though.
Okay, show it.
Yeah, I'll come back to the ostial dia.
Yeah, show the ostial diagonal to my colleagues there, all the expert. I'm not the
Yeah,
expert
so
on
I
OCT,
start
but
from
show
the,
us.
just the proximal of the D1. The stent is well expanded, and then the lesion is covered. And sorry, I'm hiding this dot. It's better.
And make a longitudinal also, right?
Sure. Yeah, exactly. We see.
Look
the
at that.
Yeah.
Look
Exactly.
at that, Roxanne.
You win, Dr. Sharma.
Yeah. All right, we are
Good
done.
work,
We can go
Dr.
to room
Sharma.
1 now.
Yeah, and a node edge dissection well expanded. Yeah, perfect.